Thanks for joining us today. This is Ask the Mayo Mom, and I'm Dr. Angela Mattke, pediatrician here at the Mayo Clinic Children's Center in Rochester, Minnesota. If you're just joining us for the first time, Ask the Mayo Mom is a monthly show where we talk about common pediatric health conditions, and I usually bring on a guest in a specific specialty area to help me answer questions and learn more about these topics. And today I have two guests with me. I have two pediatric urologists joining me, and we will be discussing pediatric-related issues and especially some new innovations that we're doing here at the Mayo Clinic Children's Center, specifically fertility preservation for children that may be undergoing procedures or treatment that could affect their fertility in the future, and also be discussing robotic surgery. We'll also be taking questions, so please make this an engaging and interactive session for us. So send your questions on the Mayo Clinic Facebook website, and we will try and take as many questions as we can throughout our session. So thank you both for joining me today. Dr. Candace Granberg is joining us, as well as Dr. Patricio Gargollo, excuse me. Thanks for having us here today. Would you like to start? Just tell us a little bit about yourself, Dr. Gargollo.
Yeah, absolutely. It's a pleasure to be here. Thank you. I'm one of the newer additions to the Pediatric Urology team here at the Mayo Clinic. I did all my training back east at Harvard Med School and Mass General, and I specialize, again, like you said, in all aspects of pediatric urology, and just very excited to be part of the Mayo team.
Thanks for joining us today. I'm excited to hear about what you're doing with robotic surgery as well. All right, Dr. Granberg, can you please tell us a little bit about yourself?
Sure. Thanks again for having me as well.
Yeah.
I'm originally from North Dakota, so this is close to home for me. And I did my training here at Mayo Clinic, and then I actually did my fellowship under Dr. Gargollo down in Texas, and then was blessed to have an opportunity to come back here on staff, and we've made Rochester our home.
All right. Dr. Granberg, can you tell us a little bit about what you do as a pediatric urologist, and what kind of health conditions that you see in children with pediatric urology-related issues?
Sure. So basically we take care of both boys and girls, and we do anything that touches the kidneys, the tubes that drain the kidneys, the bladder, and the external genitalia and the testicles. Anything on the inside that would affect fertility, anything that urine touches. And so you might not think kids could even get kidney stones, but kids get kidney stones. And we take care of anything from complex things that children are born with that need to be fixed, or things that develop along the way. So you can have dilated kidneys, blocked kidneys, urine that goes backwards to the kidneys, accidents during the daytime or nighttime, problems with their external genitalia when how it was formed. Sometimes boys have one testicle and they should have two. And so we do lots of clinic visits to look for any abnormalities, and then we do surgery to fix them.
Okay, great. Thanks for explaining that. So let's move on to talk about some of the new innovations that we're doing here, specifically in pediatric urology at Mayo Clinic. And one of them that I'm really excited to hear more about today is called fertility preservation. Can you tell us what that means and what exactly it entails?
Sure. So there's times when people are going to undergo some sort of treatment for something, usually cancer, where they get medications, chemotherapy, or they get radiation, or they have a surgery that will affect their future ability to have children. And so in grown-ups, there's lots of ways that they've looked at this ahead of time, and they can help preserve their fertility before they have those treatments, but it really hasn't been available in kids that are prepubertal. So this is a new option that we're now able to offer for kids that are diagnosed with cancer that will undergo treatment to give them the hope of having some fertility preservation in the future.
So what exactly do you do to preserve their fertility? Does it entail surgery, or is it something that's non-surgical?
It is surgical, and so there's a difference between girls and boys. And so what's always been done is the post-pubertal kids, because they're already making the stuff they need to have babies. For the prepubertal kids, it's highly experimental, but very promising. And so for boys, it involves taking either some sperm directly from the testicle, or taking a little piece of the testicle and then freezing it and saving it for the future, doing research on it, and then hopefully using it in the future for them to have their own children. For girls, it involves taking out the ovary and then down the road unthawing that, and then or thawing that back out and putting it back in so that they can have babies. And so although it is highly experimental in some ways, you know, these kids are diagnosed when they're babies, toddlers, young children, and they've got years and years before they're hoping to have kids, and we're hopeful that in that time we're able to identify ways that we can allow them to have their own children.
Absolutely. Are there certain types of cancers or types of medical conditions that would put children at higher risk for losing their fertility in the future?
Yes, so we actually put children into categories of high, intermediate, and low risk to determine who should undergo fertility preservation techniques. And so the high and intermediate groups are the ones that we're the most worried about their fertility. And those are the kids that are undergoing radiation to their entire body or to their belly or pelvis, if they have to have a testicle or an ovary taken out for any other reason, if they're getting certain chemotherapy drugs that will affect how their cells divide so that they can't have babies in the future. And so depending on what chemotherapy agents they're getting, what type of radiation, what type of surgery they're getting, we put them into those categories, and then we look at their age and have they hit puberty, yes or no, and then we're able to put them into the groups of what type of surgery they might need.
Okay. Does the timing matter at what point you would undergo this surgery?
So the nice thing is we're able to do this at the same time that they're already getting a port or a central line placed to get their chemotherapy. So they're not being put to sleep an extra time for any reason. They're already asleep. For girls, it's done laparoscopically, so they're tiny little incisions into their belly, so that's a very quick recovery. For boys, we just make an incision right in their wrinkles of their scrotum, and it's a very quick procedure. I think it takes us less than 15 minutes from start to finish. And so it really doesn't add a lot of extra time to their case, and again, it's not a really painful incision.
Okay. And you anticipate that in the future they will, after undergoing their chemotherapy, their radiation, what is the time frame when they would be getting their testes or their ovaries being placed back in? Has that been determined yet?
So there's been actually over 60 live births documented for cryopreserved ovaries and then having reimplantation, and so that's great news for girls. For boys, it's a bit more experimental, and they've done animal studies which have been great, but humans are not mice, are not baboons, and so we're hopeful that it will translate to humans down the road. But really it just depends on the age and maturity of the child, and so all the tissue gets stored and it's very protected. So some parents worry, well, my child has cancer and now you took part of their tissue. What if someone else tries to make babies from the tissue? Absolutely not. And so if a child happens to pass away from their cancer, their tissue is saved for research purposes only. It's not put into a sperm bank or anything, if you will. Same thing for the girls. And we can do a lot of great research with that tissue. So they're really helping lots and lots of other kids down the road with the tissue that we take, and then part of their tissue is saved just for them to move forward and hopefully have babies.
So you mentioned that in girls there's been successful live births, in boys it's a little bit more experimental. Is this a part of an experimental research study that's being done here at Mayo Clinic? And
yes.
Is this unique that we have this here at Mayo?
Yep, there's actually a large onco-fertility consortium which involves several academic centers around the country, and we're part of that now. And so we all follow the same protocol, and it's approved, and it's very defined how much tissue is taken out and where the tissue goes. We test all the tissue to make sure there's no infections, anything like that. So it's a big, centralized bank of tissue, and then we do our own research here as well.
Okay.
So it is new here for the prepubertal kids, and we're really excited that we get to offer it, because in the past, kids really weren't living very long after their cancers. In the 1940s, 1950s, survival rates were only 20%, and now it's upwards of 80% for most pediatric cancers. And so these kids, now 1 in 250 adults is a childhood cancer survivor. And so these adults have been asked, what sorts of things do you wish you would have been told when you were undergoing these therapies? And they universally say, I wish I would have known my options. Even if it meant losing part of a testicle or an ovary, if I would have known that was available, even if it was for research, I would have gone for it. And so it's those sorts of things that have led to our consortium making this available for kids, and it's really exciting.
That is really, really exciting. There's so many families and children that this affects. We have a question from the audience, and it's a really interesting one. Is there a risk of rejection when you're receiving your own ovary or testy that's being reimplanted?
Usually not, because it's your own tissue, and so the difference from getting, someone giving a kidney to somebody else, they have to do lots of testing on it, but when it's your own tissue, it's not an issue. And
they shouldn't have to take any immunosuppressive medications that would prevent your immune system from attacking it, right?
Correct.
Okay, very good. We have another question too. It says, can you discuss some signs, symptoms, and diagnostic procedures that would be available for a boy with urethral stricture in a 9-year-old? So this is a good question. We were going to be getting to something like this earlier, but let's see. Do you want to take that question, Dr. Gargollo?
Yeah, absolutely. I mean, stricture disease, or just the narrowing of the urethra where the urine comes out, is not extremely common in children, but we definitely see it. Usually, again, because it's a blockage of the urinary tract, we see children that have a lot of issues emptying their bladder. So they may have some urinary incontinence or accidents during the day. They may have to strain or push to void. Certainly, if there's any history in the past of trauma to the area where the urethra is or the penis, usually a bad straddle injury or sometimes motor vehicle crashes, they can cause damage and problems with the urethra. But again, it's usually recurrent urinary tract infections with incontinence and straining to push are the main signs and symptoms. Okay. And the best diagnostic test is what's called the retrograde urethrogram to look at that stricture. This can be done with ultrasound guidance or not, and basically that just involves injecting a little dye through the little hole where the urine comes out in the penis and taking a look at where that stricture is. Depending on the length of the stricture, the severity of the stricture, then you can have different treatment options ranging from very minor endoscopic procedures, which we do with little scopes and an itty-bitty little knife to open that area up, to more definitive, what's called urethroplasty surgery, where you actually cut that little disease segment and then sew the two ends back together.
Okay. So to kind of answer that question, just summarize, it sounds like they need to get a little bit more information, they need to see their specialist, they need to do some diagnostic tests to determine what they're dealing with and to help determine the severity so they can determine the treatment. Is that
absolutely.
Kind of summary? Okay, sounds good. Well, let's go back to talking about fertility preservation. I have a couple more questions. Are there other places, is this commonly done at other academic institutions in the United States for pre-pubertal children?
Yeah, there's actually not that many sites that are in this Oncofertility Consortium. We're one of the only ones in the Midwest. We're the only one in the upper Midwest, and so what's great about a place like Mayo is we're so used to treating cancer. We're a cancer center, and for kids, on top of the fertility preservation option, we have the proton beam center, which is also very unique. Not a lot of academic centers have this. So when parents want one-stop shopping, they want their kid to be cared for by the multidisciplinary team or lots of doctors and nurses. To have it all done in one place is really reassuring because we all can communicate with each other, and we're able to care for them. We have all of their records, and so for them to come here, we have lots of different options to take care of their cancer, offer them fertility preservation, and then if they need to get followed up back home, we'll communicate with their home physicians as well. So
what if a parent was listening to this and they wanted to get referred? How would they go about getting into this program here?
We have a brochure now that has some contact information that we can certainly put on the Facebook page for Mayo Clinic. And all they do is contact our coordinator, and so our coordinator will then ask for the outside records and find the right person to send them to, and we get people in as soon as possible. We have same-day openings, next-day openings in Pediatric Urology, and we're always happy to be the portal for people to get into Mayo Clinic for any urologic or cancer issue.
Great. You mentioned that there's a multidisciplinary team that's involved with this. Can you talk about some of the other specialists that are involved in this research study with the children?
Okay. Yep. So reproductive endocrinology has been key because they're used to storing sperm and storing eggs for the adults. So they were key in it. Dr. Asma Javed is one of our pediatric gynecologists, and she was instrumental in getting this through our approval process. And the general surgeons are involved in the ovary harvesting, and the pediatric oncology team is phenomenal. They're basically the quarterback of your multidisciplinary team, and so they're the ones that act as their primary care provider to determine, do they need radiation oncology, do they need chemotherapy, can we preserve their fertility, do they need proton beam, and what sorts of resources do we have here for them. So it's a great team, and we're very good at communicating with each other. Sometimes at an academic center it can be very spread out, and you're seeing people all over, and here we try to centralize everything so the patient can stay in one room and we all just come to them. And so it's already tough for a parent to go through their kid getting diagnosed with cancer, and to make them go all over the place. It's a very tiring day. They go through lots of tests and procedures, and we just try to make it as simple and compact as possible so they can start their treatment right away.
Okay, sounds good. Well, that's really exciting. I look forward to hearing about your enrollment and new patients and patient stories that are successful going through this program. Well, let's move on and talking about robotic surgery. So robotic surgery in children sounds very sci-fi. Can you tell us a little bit more about what that entails?
Yeah, absolutely. So robotic surgery has been around for a couple decades, and people, exactly like you said, have this conception of this, robot operating on their child. I mean, really, it's just an extension of what people know as laparoscopic surgery. So you're doing surgery with very small instruments that allows you to have very small incisions. What's different about, say, robotic surgery is that the operating surgeon is controlling these instruments through what's called a surgical robot. So the robot isn't operating on the child on its own. We're controlling all the instruments. And what is different and better for robotic surgery versus straight laparoscopic surgery is that it allows us to do sort of more intricate reconstructive procedures where you're actually kind of rebuilding the way the anatomy should be rather than just removing diseased organs, which we do a lot with laparoscopy.
Okay.
And that's what's really unique about this technology. It allows you to still use all the advantages of laparoscopic surgery, which is the small incisions, but you can rebuild and reconstruct things, which again, it's just a very unique problem, and it's very common in pediatrics especially. We see it a lot, so it's a really nice portal of technology that's available to us.
What would be an example of a condition that would be a good candidate for using the robotic surgery in children?
The most common thing we treat is what's called ureteropelvic junction obstructions. That's basically just a blockage like we were talking about earlier with the urethral stricture. It's basically a blockage preventing urine coming out of the kidney down the tube called the ureter into the bladder. For whatever reason, there's many different types of these narrowings, but there's a little narrowing there, and usually we just, again, remove that little narrowing and reconnect the two ends back together, just like a garden hose, basically. That is the most common, but there's a lot of other different procedures, sometimes for what's called urinary reflux, where the urine is going up to the kidneys abnormally. We can do a ureteral reimplant and many, many other procedures.
Okay, great. So in what ages of children would you consider this? Is there a too young or too old where robotic surgery would not be available?
I mean, honestly, with the existing technology we have now and sort of the advances, there's not really that much of a problem with the younger kids.
Okay.
Now, in the babies less than 6 months old, just from anesthetic considerations, we tried to limit elective cases in children less than 6 months old if we can. But really, there's no age limit. I mean, we could, in theory, do these kinds of surgeries in a 1 or 2 month old if necessary.
Wow. What's the youngest age that you've operated on?
I've done a 1 month old, yeah.
Wow.
So I did a pyeloplasty in a 1 month old. That's the youngest I've done. But thankfully, most of these kids can wait out a few months until the risk of anesthetic goes down.
Right. What would be some of the advantages of using robotic surgery versus a typical laparoscopy?
Well, again, it allows us to reconstruct things and sew and build, the anatomy that's kind of abnormal. And what's really interesting is that in pediatrics especially, I think there's a lot of doors that we haven't quite examined or opened where this technology is going to be very available and very helpful.
Okay. Is it mostly being used in urological procedures at this time in children, or is there other areas of surgery that are using it?
I would say that in urology, it's definitely where it's most robust. Our general surgery, pediatric surgical colleagues, our pediatric gynecologists definitely use it. But I think from a volume point of view, urology, just again, because we're reconstructing so much anatomy, internal anatomy, it's probably where the highest volume is right now.
Okay. Now, are there many centers that are using robotic surgery in children?
Well, it's definitely increasing. I mean, I was, again, very privileged to train at Boston Children's Hospital, which was one of the very first robotic surgery centers. And I would say there's, maybe about 6 or 7 major robotic centers where the volume is really high. And again, the technology is, being implemented more and more as, as time goes on. Okay.
Will there ever be a role for this in fetal or prenatal surgeries using robotic surgery, or is it already being done?
That's a great question.
Yeah.
I really think that in pediatric surgery and pediatric urology, that's the avenue of the future.
Okay.
We have just hired an amazing maternal fetal medicine surgeon here, Dr. Rodrigo Ruano, to head up our fetal surgery program.
Right.
And that's, I think, where the really exciting and interesting future with this technology lies.
Is this still considered an experimental form of surgery, or is this pretty standard accepted form of care for children?
It's very standard and very accepted for just, again, the routine things. I think, again, back to your question about fetal surgery, that's certainly going to be more experimental. And I think, again, in the next 5 to 10 years, we're going to see some really interesting things come up with that.
Okay. Have they been able to study any outcomes with children after doing robotic surgeries versus, standard laparoscopies, and seen any differences in outcomes?
Yeah, well, the common conditions we've definitely looked at, for example, the pyeloplasty, which is what I was talking about, the most common. We know that there is a significant advantage about doing these procedures with what's called minimally invasive surgery versus open surgery where you had a big scar underneath your rib cage, very painful. With the other procedures, it's in the process. And again, the main thing to do is to find the right technology for the right patient. And I think in some of the more unique conditions that we treat robotically, that's still being asked, and the answer's not still yet available.
Yeah, absolutely. So there's going to be a shorter recovery time for children with this. It sounds like definitely less external scars, and kids are going to get back to doing what kids do, being rambunctious and running around.
Right, absolutely. And what's also, not really talked about and discussed is parents get to leave the hospital sooner with their children. They get to get back to work sooner. And certainly if you have, parents that are working, that's a very important consideration.
Yeah, absolutely. Some of those intangible things that we don't always think about are definitely going to be an advantage to this.
Yes.
Okay.
I'd love to add one more thing.
Yeah.
Dr. Gargollo
Yeah.
actually developed a technique to make the scars even more non-visible than the standard laparoscopic approach. And so when you think of laparoscopy, some people think of like barbecue skewers all over your belly so instruments can work. And what he developed was a way to hide them so that if you were wearing a swimsuit or if your shirt was off, you wouldn't see all of these crazy poke holes all over your belly. So if you want to talk a little bit about that, I think that's really revolutionized why you use the robot for certain indications. And it really is something parents are going to notice right away, and kids notice. They grow up, and that scar that they had that was small starts to get bigger. So if you can hide their incisions a little bit better, it's a win-win.
Yeah, can you tell us a little bit more?
Oh, yeah. Dr. Granberg does all my PR for me.
Yeah, absolutely.
So that's called the hidden incision technique or the hides technique. And basically the idea is just, again, we put those little incisions, which they're about the size of a dime, but they're very visible, especially if somebody's prone to keloid or kind of ugly scar formation. If it's up by the belly, child's in a bathing suit, child's not wearing a shirt, you're going to see it. So what we do is we just move everything below the bikini line. We either use the belly button where you're not going to see a scar, or all the ports are way down by the bikini line. So again, everything that underwear or a bathing suit would cover, you're not going to be able to see those incisions. So nobody would actually know that that child has had surgery.
Wow, that's really cool. Very cool. All right. Well, we have one question that I would like to take, and this isn't related to robotic surgery, but it says, when do you typically intervene with kidney stones in younger children? And in this specific question is about a 4-year-old with Fanconi syndrome. So it's a little bit more specific, but in general with kidney stones, when do you guys decide that surgery is going to be the best option?
It depends on the size of the kidney. It sounds like this question is about large stones, but it depends on the size and the location and how many. So most people have 2 kidneys. If you have stones blocking off both kidneys, that's an emergency. We'll intervene. If you only have 1 kidney and you have a stone, we'll intervene. Sometimes stones are just hanging out up in the kidney and they're not doing anything and they're tiny, and we just keep an eye on those. We try not to operate unless we have a reason to. So reasons to operate would be if it's blocking off their urine flow, that's painful. If there's any infection, then they can get super sick because it can get into their bloodstream, and then they end up in the ICU, and it's not a very good situation. Or if there's so many stones that are in the kidney, it actually starts to damage the tissue of the kidney, and so the kidneys in kids are developing, and so if you have a 4-year-old child like this with large stones, if the stones sit there too long, they definitely can cause some damage or scarring of the kidney itself.
Okay. And what type of surgeries do you guys do for kidney stones? Are you using some of the laser techniques, or are you doing more in through the ureter? You want to explain that a little bit?
Yeah, I mean, again, like Dr. Granberg says, it really depends on the size and location of the stone.
Sure.
We have external shockwave lithotripsy where everything's on the outside and we kind of bust stones open. We have very small little cameras that we can go into the urinary tract and use lasers to break up the stones. And in the cases where the stone burden, the amount of stone is just very, very significant, we actually make a little hole in the back, get straight into the kidney again with these little cameras, and either using ultrasonic energy or laser energy, we break up all those stones and remove them. Now we have a complex stone center here at the Mayo Clinic, so we see some of the hardest and most difficult stones out there. And again, Dr. Granberg especially sees a lot of these, so we have a lot of experience with this.
There's certain conditions that predispose children to having kidney stones. Can you guys talk a little bit about maybe what some of those syndromes are that cause more kidney stones to develop?
Yeah, so I think that's what he was referring to as well, is we have this rare kidney stone consortium. So all those sorts of kids you're talking about fit into these categories of they have a syndrome that predisposes them to making stones, or they make certain types of stones that are just difficult to treat because they keep coming back quickly, or they just make so many of them. And so cystinourics are probably the most common. A cystine stone former, they start when they're children and they just can have them their whole life. And so our pediatric nephrologists here are absolutely wonderful, and they'll help diagnose these kids early and then give them ways to prevent stones from forming as they're growing. We watch them very closely. But there's several, even something as simple as taking a seizure medication. An anti-seizure medication can actually lead to stone formation. And so, you know, the rarer stones are kids that have syndromes where they're missing some sort of enzyme or something that's normal in a human body to prevent stones from forming. and they just make stones like crazy starting in childhood. And what's interesting is even just regular old stones that grown-ups get are starting to show up more and more in kids. And so we wonder, is it their diet? Is it their weight? You know, what is it that's making kids get calcium stones earlier in life when they should be grown-ups? And so lots of places are studying stone disease. Our nephrologists are following their urines. And you know, the rarer ones fall into the big consortium that we have here, but we certainly see just regular old kids coming in that just have a kidney stone for no unexplainable reason.
Okay. Yeah, we had Dr. Sasson, who is a kidney stone specialist, pediatric nephrologist. We talked a little bit about that, but I think it really should be like an individual kind of basis determining which approach, it sounds like, right?
Yes.
For which, depending on what type of stone former you are and the severity of the stones, where they're at, what your treatment options would be. Okay. Well, we're getting close to the end of our time, and I think it'd be really useful for us to talk about bedwetting and what we typically refer to as enuresis. Let's start by talking about what is a typical pattern for when kids should become continent through toilet training. One of you want to touch on that, Dr. Granberg, maybe? Or okay.
Sure. You know, the toilet training age is very individual. You know, maturity as far as neural development is different for every child. So even if you have 4 kids, the one who potty trained when they're 2, the next one might not potty train when they're 2. And so every parent and teachers and preschool teachers should understand that is very individual. And so kids who are able to tell you that they have to go are ready. And so unfortunately, there's been a phase where parents will say, I want my potty trained child to go to preschool, or there's schools that won't accept a child unless they're potty trained, and that has led to some of these potty training boot camps and one-day potty training. And what happens is the child is trying to pee more often than they should. Their bladder won't realize what is full and when should I have to go, and then they develop some dysfunctional voiding habits, and that's what we see in some of the older children. Then they're having problems. And so realistically, there's not a magical golden age of toilet training. It should be individualized, and it's really when the child can say, I have to pee. They can sense that they can pee, they can sense that they're wetting, they can tell you when they have to poop, they can sit on the toilet and poop and pee, and it's not going to be overnight for most kids, and it shouldn't be a deadline. And so it's really, again, a spectrum. It can be, you know, the biggest problem we can see sometimes is kids that toilet train too early. The bladder's just not ready for a large enough volume of urine to stay dry longer. And so we try not to encourage the boot camp training, trying to get them done by a certain age, and just letting the child tell you when they're ready.
Absolutely. Dr. Gargollo, can you talk a little bit about when is a typical age for children's bladder to be matured enough to be able to hold the urine throughout a typical night's sleep? Or is that also going to be very individualized for children?
It really is. I mean, again, it's a developmental thing, and then you know, the children that we see that have daytime dryness but nighttime accidents or incontinence, they tend to be very, very heavy sleepers. They tend to be boys, and normally we do not recommend anything in particular until the child is really at the point where it's becoming a social problem. So we see 6-year-olds, 7-year-olds with this issue. As long as there's no daytime incontinence, there's no urinary tract infections, there's no history of urologic problems, and it's just isolated wetting at night in an otherwise healthy child, we really try to have parents not intervene until it becomes a social problem. And then we have different things we can offer to try to treat that issue.
Okay. Is there any risk factors for when kids are having problems with dysfunctional voiding? One, like a common thing that you see that if you eliminate first could help down the line for them?
So the most common thing we see that's associated with dysfunctional voiding, urinary problems, daytime incontinence, urinary tract infections is constipation. Okay. I mean, that tends to be rampantly common in these patients. And usually we treat the constipation, the urinary symptoms get significantly better.
Okay, great. I think we're nearing the end of our time here, and this was really enjoyable. I learned a lot about what you guys are doing in pediatric urology. Thanks for joining us today.
Thank you for having us.
Yeah, great. So next month we're going to be having one of our pediatric cardiothoracic surgeons, Dr. Joseph Deraney, who is a specialist in congenital heart disease and especially in the area of Epstein's anomaly. And so please join us next month to be discussing about cardiac and surgical interventions with congenital heart disease. Thanks, and everyone have a great day.